vicious circles may be far more likely and plausible than the idea of root causes. So these two approaches, experimental psychopathology, together with behavior therapy tradition, and network theory, converge from symptom to symptom transitions. And I think the contribution of network theory is that it shows the presence and the strength of symptom to symptom association. That's very important because we may have intuitions about which symptoms are very crucial to a disorder and which are not. And again, I can't remember, did you present the data on the Chinese earthquake this morning? No, you didn't. But you said something about the sleeping problems being central. Right. What I recalled is that the study showing that sleeping problems in people suffering from PTSD in a certain their sleeping problems are very central, and that's counterintuitive. At least it's not what you would expect from the literature. So it can really help you coming up with new ideas, with practical implications, with research implications, and it can really help you set the agenda for new studies. Because it empirically shows you what symptoms are central, connected to other ones, and which are not. And I think that clinical experience may be informative. It may suggest hypotheses. The hypothesis may be wrong. And it's very helpful to have, some external, strong empirical evidence for that. So it shows centrality within a network. It explains comorbidity. And it's a heuristic for research and for clinical work. Of course, there's some crucial weaknesses to the network approach, or weaknesses, the things that cannot be solved by a network approach, and this is often the explanation of how symptoms affect other symptoms, because the examples that I gave you from, for instance, depression, I say, well, you get a depressed mood, you get some rumination, you get sleeping problems, you get fatigue, you get concentration. These are all self-obvious, they're self-evident. You don't need to have any psychological knowledge to understand this is going on. But there's other ones, other transitions that are far less obvious. Even the notion that safety behavior and avoidance behavior can reinforce anxiety. That's not a self-obvious, self-evident sort of notion, let alone relationships between I like the work that Ruvi Dar was presenting on access to internal proxies. And not having access to that, and because of that, seeking for other ones, and thus explaining how obsessive uncertainty may breed rituals being external proxies. So there's a transition from one symptom to another one that is not self-evident, and you need psychological expertise. And this is where psychology or experimental psychopathology comes in, testing whether or not relations between symptoms are actually causal or not. So you can test the issue of causality. And there's another thing that I've been talking about this during the break. These network analyses which are around now are typically done, and perhaps exclusively being done, I don't know, but typically being done on symptoms as defined by DSM or whatever you got. But this, of course, is not necessarily the only source of nodes in a network. And again, the work of Ruvi Dar may be interesting, because you've heard it. Basically, he said, well, these patients, OCD patients, have bad access to internal states, and therefore they look for proxies, for external information that's relevant for them to compensate for this lack of access. And one of these are the rituals, which you will find in a network analysis, because the rituals are included. But if the other ones are monitoring, as he suggests, he may be right, he may be wrong, but I think he's right. But never mind, it's the argument that counts now. And if the other one is doing experiments, a sort of experimental-like investigations. The example of a man who's afraid of losing his penis, and seeing what is going. Am I really hurting myself? These things are not included in present network analysis simply because they are not serving as DSM 4 or 5 symptoms. And if you want to have I think a sound, functionally sound network analysis, the nodes in that book should not be only the symptoms as defined by a diagnostic symptom, but it should be informed by sound and valid theories, and should include all the relevant behavior, relevant emotion, relevant cognitions, etc. Okay, the doen, this is Dutch, and it means to do. And I apologize again for being somewhat confusing, but two versions of it, and this is the last version, but this has been another one. Never mind. The concluding remarks are that there are that quite a few of us are enthusiastic about a new approach, a new wind being blowing in this area. And it's network theory. Network theory in itself is not very new, but this application to psychopathology is very new. It's holding a great promise, and it helps us looking at DSM sort of classification in a different way, doing more right to what we're doing as behavior therapists, and it sort of explains the important things that DSM became so famous about, acknowledging that yes, there are clusters of symptoms, complaints, phenomenon out there that reliably cluster, the OCD, the depressions, the addictions, etc. It's there. Yes, there is comorbidity, and it's accepted, but it's giving us much more. It's suggesting that it's no surprise that even 1,000 million, 700 million of euros has not resulted in reliable markers. It may be because the emperor has no clothes, because there are no markers. Oh, very general ones, but not the gene specifically coding for a disorder. That's what it gives us. And it nicely converges with work that's being done in experimental psychopathology. So all sorts of experiments where people manipulate one type of symptom to see whether other types of symptoms or symptom-like phenomena are affected. Testing theories about how one symptom may affect the other one. And I do think that experimental psychopathology has got things to offer to network theory, in the sense that it gives explanations of how symptoms reinforce one another, and it gives explanations for that, suggesting new nodes for the networks. On the other hand, network theory is very likely to have good effect, provide good inspiration for experimental psychopathology. So they may mutually reinforce one another, much like psychiatric symptoms do. I'd like to thank you for your attention. Thank you very much. If there are, yeah, good run.
I wanted at the beginning of the talk, although I'm not sure it's the one you wanted to give, but I'll do it anyway. I almost feel by defending diagnostic systems, but I think you also need what they're used for, and that's when somebody a clinician decides there is a certain symptom cluster and gives it the label, depression, OCD, whatever. The next step, it's for the next step, and that is choosing the treatment for this cluster. And one knows meta-analysis has found such and such treatment is the best, is that timing to support, timing to whatever. So it's facilitating the choice of treatment for the patient.
Sure.
And the other one, I think that this is not the minor concern, is to make sure that in research, that the patient groups we research on are the same as the colleague has researched of far away. To make sure symptoms are
sure.
And so it must be the same group as somebody else says they've investigated and found such
Sure.
and such.
I fully agree. I mean, having labels descriptive labels helps for choosing relevant therapies, because you know you can profit from research being done elsewhere. So if this is the same type of patient, then the research that showed that this type of therapy is typically effective pharmacologically, behaviorally, apply it here. And it helps communicating with colleagues. And I think there's no problem with giving labels to groups of symptoms, but there's a very, very dangerous, very, very common misconception about this, that is that this label tells you anything causally about the disorder. And this is not the case. And I think perhaps we should really stop using the word disorder and symptom, because inherent in them, and you really are very easily bewitched by the idea that if you use the word symptom, you already imply that it refers to something underlying, and if you then use the word disorder, it's clear to everybody. So you're using one is using very sort of dangerous terminology. The dangerous terminology is that if you use it, it's very hard to avoid tautological reasoning. But I agree entirely with your idea that we should, the idea of giving codes or names or labels to clusters is very helpful. And not at odds with yeah, please.
Yeah, sorry, I don't know if I've quite understood it. How much you want to disagree with it, if I haven't understood it correctly, because I don't think, I just think it's agreeing with what you said. I don't think people quite understand how profoundly the categorical diagnostic systems fail. So, for example, just to take some specific points, if you look at the genetics of psychiatric disorders, you don't follow in any way the diagnostic systems at all. There are no genes for schizophrenia. They already been found on it. Everything is massively polygenic because the diagnosis is non-specific. Certainly in the severe mental illness area, if you look at antipsychotics, well, everybody gets antipsychotics now, why? Because the diagnosis doesn't really predict who's going to be responsible or not. So when you call bipolar or equal schizophrenia, you give an antipsychotic. So, the only virtue I would say for the existing diagnostic codes and things like that is that they're just cognitively simple. They're just easy to use. But apart from that, I don't see any, it seems to me that the network approach is a huge advance. The problem is, how do you translate that into something which ordinary clinicians will, I think that's a real challenge.
Yeah, it's absolutely a challenge. I do agree with that. There is the promise of making individual networks. And Danny Bosbaum and his colleagues were working very hard on that, getting technology where you sort of give potentially relevant notes and send a patient out to just monitor for a couple of weeks and construct a network for this individual patient, which sounds far away, but they're pretty clever in the mathematical calculation underlying this. So there may be very interesting progress in this area. Thank you. Yes, please.
How about biologically caused disorders like
But what about biologically premenstrual?
Would account for neurobiologically caused disorders?
Of course, disorders.
Or effects on moods, for example. It could be the case that maybe the certain region in the brain is deactivated, and therefore people became more callous. How would you account for that in this network?
Well, I guess the network theory in itself does not rule out any biological contribution or basis. It just says that, well, maybe perhaps you would say there's a weak version, or a weak version, a strong version of network theory. A strong version would say, well, psychiatry is entirely about networks, and there's no underlying pathophysiology or pathophysiology explaining any aspect of the disorder, which I think very people would believe. It would, the weaker version would be that it's sort of marginal. I mean, in the case of premenstrual syndrome, there may be something to it, but then again, the evidence, well, there's a lot of evidence for placebo sort of things. I happen to know the research from 10 years ago. But I mean, there wouldn't be any reason from a network perspective to deny that and say it may be one of the factors. It can be one of the nodes that triggers other symptoms. But you just realize that once a symptom is triggered, and you get nervous, your mood is lowered. You may have social problems. There may affect on other interpersonal, intrapersonal phenomena.
Well, my next question would be then, should we keep such disorders within the next DSM, or should we base it on this network theory?
I mean, I think ideally the DSM would be a truly descriptive system, which now it's not. I mean, on this presentation I have some quotes from DSM-5 in which you can read that even the people who wrote the DSM are victim of this tautological reasoning. So you see, for instance, you give the diagnosis GAD if these symptoms are present, unless the symptoms are better explained by another disorder, implying that disorders do explain symptoms. Apparently GAD explains symptoms unless another disorder explains it better, so that even they fell victim to this very... So, but ideally, I think we really should have an empirically based descriptive symptoms of clusters of problems that people experience. They come in clusters, and we better realize that they do come in clusters. And do it empirically and do it good, and realize that there's a lot of comorbidity, and comorbidity is not an exception, but comorbidity is sort of the rule. Yeah.
So I had the hope that you will show a map of obsessive compulsive symptoms, like a network map. So do you have it somewhere in your slides hidden? Or?
I didn't fulfill a hope, but what was the hope exactly again?
That will show us a network model of obsessive compulsive disorder.
Oh, I didn't. No, the hope has been in vain. But it could be. It would be an interesting challenge to do it, well, at least hypothetically.
Yeah. So no, if you don't have a real, you can come up with a hypothetical. So.
Sure. No, but that would be interesting to do that and see what such a network would like, and then confront it with, then throw in all the nodes and go to and then put them into the network software. Because as I understand it, it's not that the program is free for everybody to use, so it's sort of user friendly. So if you have data, you can put them in the system and calculate all the types of networks.
I was wondering, because experience sampling method is more and more used as a kind of a research tool, but I was wondering if it could also be used for clinicians at some point to make a sort of individual network for every patient. Yes,
and I'm getting an old man, and when I started my career in 1980, it was in a clinic where was an inpatient facility we had very severe anxiety cases, and we did sort of intuitively make sort of networks. We had sort of a holistic theory, and we had depression producing that, all the arrows, sort of a radio scheme with all the arrows going there. And this was a sort of intuitive effort to make a network. But then again, this was all based on interviews by the patients, and we know that these interviews are very unreliable. And when it comes to functional analysis, holistic analysis, being done by a clinician, I mean, I don't give anything for the reliability and validity of that. But then again, this holds the promise of having it empirically validated. And as I said, the notion of networks and vicious circles that are not very new to behavior therapy, but this gives an impetus for, for making it far more sophisticated and empirically validated. There's a question here. Excuse me.
Okay. Very nice presentation.
Thank you very much.
When you think that you are systemic, you won't say that you are also linked with Gregory Bateson's thinking, the famous Gregory Bateson, because the father of the systemic approach is Gregory Bateson. And is also linked to the family therapy. I worked a lot with family. Then the family become a system. There is an individual and the system of family. There are all these interactions inside our mind and interactions outside our mind.
Sure.
All is linked.
No, but I do think that these notions, that all things are linked, and this is not just output but input, and that we're talking about complex dynamic systems, that this idea has been around and it's not that new. But what is new is that you can really test it out, because I think what behavior therapists did in the 80s and many family therapists is taking the validity of their observations for granted, and seeing all these patterns and saying, well, it's an interaction of a system, but you don't know if it's a true interaction, if these are really nodes. Are they really nodes? And basically, all these observations remained hypotheses, interesting in themselves, but very hard to test in a non-clinical context. And even in a clinical context, a true test of these hypotheses would be next to impossible. Whereas now, with this technology, you can really go out and test whether this is true. And there may be some grain of truth, or more than a grain of truth, to these systems therapy applied to families. But perhaps it's very different, or the very same, and it's the great adventure is to go out and look. And we'll see. Ernst.
I'm loud enough to myself,
I can hear you, but...
Yes. So I wonder, because you're referring to the fact that you are a little bit older, and so how does the behavior therapist in you relate to this network modeling? Because in network modeling, most of the time you just look at correlations between things, and of course as a behavior therapist you think in terms of functions of behaviors and contextualized functions of behaviors, and to me those two things are not necessarily the same.
No, I think this is what I've tried to say here, that if you take a network theory, that in itself it's suggestive of causality, and it comes quite a way, but it will never be the royal road to knowledge about causality, which is experimenting. And there is also a sort of intrinsic relation between cognitive behavior therapy and experimental psychopathology. You're looking for processes that drive in other processes. And this is where network theory can learn a lot from experimental psychopathology and from behavior therapy, and the other way around. So the behavior therapist in me tells me, which is very interested in network theory, but there's something crucial missing from it. That's not to blame network theorists, because they cannot. Their methodology doesn't allow for answering this, whereas the experimental methodology is designed for answering these causality issues.
Okay, thank you.
Yep. Okay, thank you very much.
Okay, thank you, Professor Hout, for this contribution, and we are finishing, and I want to remind you before we leave that tomorrow the works will start at 9:15, and then that we will see later at the social dinner. Goodbye. Thank you. everybody.